Perfect. So what I can see right now is it now is working. So I can see a full screen that has Penelope at the top. So it's a full screen vision. Do you want to try moving forward one for me, and I'll just make sure it works?
Yeah.
Yeah, perfect. It's working great. So now that we're recording, I want to officially welcome Dr. Lorenzo Botto. Can't thank you enough. He was one of our speakers last year as well, and everyone said I should have him come back because we all got to hear from the NIH team and how they started the Undiagnosed Disease Network. And now we're going to hear about someone who is out in Salt Lake City, Utah, and decided to start their own undiagnosed disease program. And he's going to share with us kind of their journey, the stories, a little bit about how they have done their funding. And I think it's just a great story of how a clinic that's invested in patients in rare disease and progress that can be made in rare diseases without having, you know, the entire NIH behind you, which is the story we heard when you guys were live in DC. So again, if you have questions throughout, feel free to post them on the chat wall, and I'll share them at the end. Or you can always text if that's easier to my cell phone if that's easier for you. So Dr. Botto, again, I can't thank you enough for joining us again this year. You've been so generous with your time, not only with us, but with your patients. So thank you so much. And I'm going to let you take it away, and we'll go from there. Thank you.
Okay, so thank you very much, and welcome everyone. It really is a pleasure for me to be on the screen and on the speakerphone again. What we focused on last year was the development of this program. It had just started, and in the meanwhile, we've actually started it. We're close to 20 families we've seen, the last one just yesterday. So I wanted to chat with you a little bit about how we've developed this program and also give you a few examples of actual patients that we have seen and some of the benefits and challenges that we have encountered with these with these patients. We have started. Let me give you just a 1-minute introduction of myself, so you know where I'm coming from. By training, I'm a clinical geneticist and biochemical geneticist. I also have spent quite a bit of time in epidemiology and public health. So those are the two hats that I'm wearing here. One is a clinician, and the other one is someone who's interested also in the integration of genetics into population health. I would also tell you what I'm not. I'm not a lab person. I leave that to my friends who are much better at that than I am. So we'll be talking more about a few practical things here in terms of how to serve this particular patient population. So, let's start. We called our program Penelope, and if you're interested in knowing why, we can chat about that towards the end. We started it as a pilot program focusing on children with undiagnosed and rare conditions. So this is so far a pediatric enterprise done through the Department of Pediatrics at the University of Utah, with some discussion of expanding that in the near future to the adult population. I would start with actually the first patient who we saw, the very first family we saw, a 12-year-old boy with a progressive neurodegenerative condition. So basically, he started becoming blind and deaf. So progressive vision loss, progressive hearing loss, also motor regression. He could walk, he could talk, and then he could not talk or walk anymore. Started around age 5 when we saw him. Early in 2016, he was essentially wheelchair bound and was non-verbal. So he had this regressive course, which made the evaluation a little more urgent than other kids, and which is also why we saw him again with the first in our queue. He underwent many genetic tests, many imaging studies. This is a story you will hear repeated in a lot of these patients. He was seen in various institutions here in Texas, also at NIH, though not at the NIH undiagnosed disease program. I want to say that because they would have found this. So he had this, what we call a diagnostic odyssey, about 7 years long so far. And this brings up to us sort of one of the core questions, the core issues here. What is the diagnostic value for this very intensive sort of evaluation? And what many families and providers tell us is that there are sort of 5 main questions that they have. The first one is, what is it? I mean, they want to end this diagnostic odyssey. There is fear associated with the uncertainty of knowing what's going on. And that is also related to the second question, what's going to happen to my child? The uncertainty leads to not knowing what will come next. Will it get worse? Will my child, die early? So the question of outcomes. Close to that, especially for families, young parents, is, why did it happen? So finding the cause is important, and the hope is that by knowing the cause, one will know how to treat this in a more targeted fashion. We say cure is always the hope, but realistically, I think for most of our families, we're fairly far away, but it's still a step in the right direction, finding the cause. So if some potential cure can come, if the clinical trials targeted to this specific causative pathway, one can enroll, for example, these families. And then, since we're talking about genetics and usually young families, is what will happen to my family? Am I a carrier for this? Am I unaffected children also at risk for this condition? If I have another child, what is the recurrence risk? So these are all questions that I think you're all very familiar with. And the theme that comes up when we speak to this family is that of an odyssey, so of a long and twisting journey in a fairly difficult landscape, encountering a lot of obstacles, like we like to say, being in Salt Lake City, like, the pioneers in the American West. And, what they say is that this journey has been long, it has been hard, and it has been lonely. One of the values they put on finding a specific diagnosis and finding even if only a name without a cure, is that then they're able to find other families and connect with them. So the theme of loneliness actually looms large when you speak to many of these families. And the hope of this program is to reduce these 3 aspects, make this long journey a shorter one, making a difficult journey an easier one. It will never be easy, but we'll try and make it easier by being there with them and then trying to take some aspect of this loneliness away from this. So why is this a challenge? Well, I think mainly because the diagnostic journey that works well for many conditions really doesn't work well for this specific group of patients. And this is because we're trying most of the times to find this proverbial needle in the haystack, and the needle is actually always there. It never goes away. It's just a small needle in a large haystack, which is sort of the diagnostic space, if you will, a large diagnostic space. And we try and find this over time. And most families go through this diagnostic space, meaning they see various specialists that got many encounters, which are exemplified here by these triangles. They do a lot of this testing, and this testing is not efficient for the most part. It tends to be clustered, either when they see a specific specialist or when they have a crisis of sort, like a hospitalization. And then between these crises, often there are long waits in which neither the provider nor the specialist nor the family knows what to do. And these long waits are actually a hard time for many of the families. So if we want to summarize this in what I call the 3 Ds, there are a lot of delays, oftentimes I think unnecessary delays in the diagnostic process, in a roller coaster of expectations. There are also defects in the process, for example, redundant evaluations. You can see a lot of these triangles being in the same place. Sometimes you have missed the diagnosis, usually because each specialist, and this is true, I think, now more than in the past, with the specialization, each of the providers tends to be able to look in depth in a smaller and smaller area in the diagnostic space. Oftentimes there are painful and sometimes also risky procedures which are done. And then I've put the 3rd D as desolation. I mean, again, we've touched upon this. The families often feel alone in this multi-year odyssey. And it's not because we are not good at the things that we do. I think there are sort of good reasons. One is that, as you all know very well, being in your program, these can be and usually are rare diagnoses. So each specialist probably has never seen it or has seen it once. Oftentimes they are unusual or variant presentations. So what we read in books really goes a little bit out of the window. They are cognitively complex, and they affect typically a number of organ systems, and not just brain condition or cardiac conditions. They are complex, and oftentimes nowadays they are technologically dependent. And I'll try and make some examples of some of the families we saw and why the diagnosis was missed. Typically the diagnosis require testing which is either not covered by most of the healthcare systems, most of the time, or they require, for example, whole exome sequences, because most of the gene panels, or many of the gene panels, tend not to be up to date with the new genetic discoveries. So I think I'd like to make the point that the challenge is not that we don't have good people. We have outstanding people in many children's hospitals. We have remarkable technological resources, but I like to think that we have, for this patient population, misaligned resources. So the challenge for us is to make this journey shorter, fewer steps, to make it faster, so not wait until the very end of this odyssey to implement some of the resources we have, and to add value to this process, to make this process of higher quality while containing the costs. And the way that I think a lot of us are thinking is to re-engineer the process, so we move what we tend to do at the end of the journey, move that much sooner, to try and make what had been so far mostly a sequential process of children seeing one specialist at a time, and for each specialist connecting to the previous one through written notes as opposed to direct and parallel discussion. So we move that. To closer, have the specialists actually sit down and speak to each other. That's point number 2. And 3, use the tools that we have. And the tools that we are trying to use are 2 main ones. One is try and extract as much information from the medical history notes. Typically, many of these patients have tens or hundreds of notes, hundreds of pages, and labs. One thing that we started to do is to restructure all of these notes in a single note that summarizes to the key points. So all of the specialists and the primary care provider and the family can see them more easily. And 2, to move more quickly to sort of untargeted or less targeted testing like whole exome sequencing for now. Why is this helpful? We want to do provide to better care. We work in an academic institution. I think also most of you do. So I think also the connection to research is important for us. So provide a means for these families if they want to contribute to research into these rare or new conditions. And also number 3, again, being in an academic institutions, as many of you are, we want to use this model to provide, let's say, fellows and young faculty a better opportunity for education into this, new model of care for rare conditions. And, all this really comes through the, wonderful program that, NIH has. I mean, we've all learned from this. I myself spent a few days and really benefited from the context from the NIH undiagnosed program. And you're all very familiar, I'm sure, with this. This is a recent paper. It's interesting for me to note the key lessons that at least I've learned by listening to Dr. Gal and reading the papers from their group. I think one of them is the value of careful phenotyping. I think sometimes this is a bit lost with the rush to purely genetic testing approach, and I think the NIH program is really pushing us to realize the value of the phenotyping, the value of the family history, the value of the longitudinal follow-up of these families. The second is the evaluation as an iterative process. I mean, oftentimes we don't get it right, the first time for a number of reasons. So we really need to commit to the family and go back and back until we figure things out. Number 3, expect new and very rare conditions, including variant presentations. I think this will come through in some of the case examples, which I'm going to show you. And then it's important not only to advance knowledge, but also to advance care. As you read in this abstract here, and some of the information that I will be giving you, we really can come up in this time and age and place. We can arrive to a diagnosis only in a fraction of cases that go through this intensive process, even with the best of people, even with the best of technology. I think it's realistic so far to assume that we will find a diagnosis in 2016, 2017 in 50% or less of cases. And so, but we really have to find ways to care for all of these patients, not only for the ones for which we are able to provide a name and a condition. So our goal is to try and learn from the NIH and other sites to improve the lives of families with undernose conditions, and by provide a path that is both efficient and compassionate to both diagnosis when we can, but also to coordinated care. And I think we can provide coordinated care or improve that coordinated care in every family who we see. And the way to do this is not only to re-engineer the process that we said, but also to really promise the families that we have an ongoing commitment with them, and that we really try and provide greater value to both the families and other providers involved, including the primary care providers. And again, I mean, we should not hide the fact that the journey will continue to be oftentimes a fairly long journey. It will be easier, but not easy for the most part. But we really try and provide them a measure of peace and a measure of commitment that will be there to help them through this. And also, and this is the second metaphor that a lot of families have, is not only that of the odyssey and of the journey, but also they want to find a home. They want to find a home in terms of finding connections with other families, but also, if you will, a medical home. The medical care for a lot of these patients, a lot of these families is fragmented, due both to the fragmentation of our healthcare system, but also to the fact that many of these kids have a number of organ systems involved. So, their care is fragmented through a number of providers, and then that is often suboptimal. They really want to find sort of more coordinated care. So what we have done here, and we will see that the University of Utah Pediatrics has set up what they call a comprehensive care program. This is a group of experts, pediatricians and nurse practitioners in the world of physical medicine and rehab that are committed to provide coordinated care to kids with complex care needs. So our undiagnosed program has partnered with the comprehensive care program in order to provide not only diagnosis when we can, but comprehensive care in all of these families. So we've developed this program with a core group who we see up here, and this reflects the specialists who are involved, most of the time, and this comes also from the lessons from the NIH program. Is the genetics group for the most part, including the biochemical genetics groups, is the GI group, is the pediatric neurology service. As you will see, most of the kids have significant neurologic issues, so we really need that expertise both for diagnosis and care, rheumatology, immunology, and also, and I highlighted it here, having the continuity in the diagnostic process through a dedicated nurse practitioner. And then we bring in additional consultants as needed. The other thing that I wanted to point out is before starting the program, we had a number of focus groups, both with parents of kids with undiagnosed conditions. We've had, say, 2 of those. We had a We had 2 focus groups with sort of the mid-level, the care coordinators, the nurse practitioners, to understand the complexities of the care process and the diagnostic as a process from their perspective. And then we held also a focus group with the clinicians who are commonly involved in kids with complex conditions, and we've tried to incorporate what has bubbled to the top in terms of value for these 3 groups into the design of the process. So let me go back to our first child, Tyler, our 12-year-old group, and this is the process that we've developed. So basically, there is a referral from usually a specialist. Each of the referrals are screened, and we can either redirect this family to what we call alternative resources if there are some basic things that haven't been done yet, and the team feels that this could get to a diagnosis fairly soon, or we accept that child, in which case there's a lot of work going in gathering and restructuring all of the medical records that have been together so far, usually hundreds of pages. And then the team meets to review all of this to try and figure out if there are certain conditions that this child might have, sort of if these tend to bubble to the top. And then for each family we developed a targeted diagnostic plan. So who will the child see? Will it be genetics, comprehensive care, neurology, GI, and so on, and then we bring the family in. The testing, for the most part now, has been mostly whole exome sequencing, and this will become clear why. Sometimes we do additional testing like brain MRI or MR spec, and so on and so forth. In green, you see the face-to-face meetings with family, and as you can see, most of this chart is not green. And this really highlights that most of the care and most of the thinking goes on outside of the clinic. This is important also from a practical perspective, because a lot of this time is not actually billable in the current healthcare environment, so we have to find ways to support and sustain this process, and we can talk a little bit about this at the end. Once the clinical testing and the phenotyping is done, we sit down again with our clinical board and try to figure out if we have a diagnosis, what it means for the child, what this means for the care of this child, and then we sit down with the family and go through all of this. If the child has not been, well, for each child we developed a follow-up plan whether or not a diagnosis has been made. We always link them to a plan for comprehensive care and or for community care with support from us. And then we also offer them a path to research. If a child has not had a clinical diagnosis based on a clinical exome, we've got ways to do more than is available currently clinically. So this is kind of to the flow. As you can see here, every child is then provided with all of our data, including a thick binder that has a lot of the information that we've gathered. This is Ash, our nurse practitioner, who follows every child from the beginning to the end and provides a point of contact for the family and also continuity for the program. She essentially keeps us on the straight and narrow. She's an integral and key part of this whole process. This is here Dr. Bale, our experienced clinical neurologist that you can see from the white beard here, and then this is part of sort of the face-to-face assessment. So what happened to Tyler, our first patient? He went through the same process, and then we were able to find the cause of his condition, and this was a mutation in the PRPS1 gene. It's an X-linked condition, which is very interesting because this is essentially a metabolic condition. It is a block in the de novo and recycling the pathways of purine and pyrimidine. So this is not really what we expected. It's interesting because before we knew about this gene, there were 3 conditions that had been phenotypically characterized, and you'll find these in OMIM from on a scale from less severe to more severe. They had actually been given 3 different names: an X-linked form of deafness, a X-linked form of Charcot-Marie-Tooth, and
what's that? RDCR and the rare disease scholar, the webinar, the monthly webinar, that's what's going on.
Oh, today?
No, not that. This is for the scholars program.
Okay. Hold on, I'm going to mute whoever's talking. Sorry.
Oh, okay.
Thank you.
I thought it was a question from one of you, which is why I stopped. No, it's fine. So you go from Arts syndrome, which is associated with very severe regression and marked neuropathy, vision loss. So you can start seeing some of the similar. Most of these kids actually don't make it to 15 years. So the phenotype in our family, in our child, includes some of these, as you can see here, and it's probably somewhere intermediate between the Charcot-Marie-Tooth X5 and the Arts syndrome. The pathway is here. The block is all the way up here, so it's to go from the ribose 5-phosphate. It adds another phosphate, so this entire pool of purines and pyrimides can be replenished in a functional way. What's interesting here is that this diagnosis allowed us to do 2 things. One is to try and figure out if there was a way to replenish this pathway through alternative means, and the other one was to see if anyone in the world has actually seen this and had tried this, and there has been. It was a group from Dr. Christodoulou in Australia who had diagnosed a family with 2 SIPs with a similar phenotype on the severe side. He had thought through this and did a small clinical trial on these 2 boys, young boys, by providing S-adenosyl methionine. And what happened was very interesting. These 2 boys, and this was a short report from him, these 2 boys had been in the hospitals because of their issues for many weeks, actually close to about 3 months, in the 6 months prior to him trying this. And in the 6 months after starting the supplementations, these 2 boys had 0 hospitalizations. So they seem to have had much less, health events. Again, very small sample size, but it was enough for us to begin working with our family and suggesting to them to start with acetylinosyl methionine supplementation. As you know, the SAM, which is the acronym for this, is quite widely available in health food stores, so it was not hard to find, and it's fairly inexpensive. So we started him a few months ago, and within a month, Mom sent us a video of this child, playing in his backyard. So this was a child who was essentially wheelchair bound. Now he could get up. He could play. This made Mom, very happy. And what was also curious was that Mom, as he mentioned, that he seems to be seeing a little better. He used to run into things, and now he does not. And he also seems to be happier. Both providers and Mom told us that he had a lot of these temper tantrums, and now he doesn't have those. So we are continuing this. Now we are going to try and get some more objective findings with an eye exam and have him seen by our rehab people to have more objective measures of his motor function. But all of this has been quite encouraging to Mom. So for this child, his diagnostic odyssey is over. This is one of the added values we think for our program. We were able to identify potential focused treatment, as we have mentioned, and also we have additional actionable information. Since this was a family-based exome, it turned out that Mom is a carrier. She carries the mutation. We phenotyped her a little more. She has some mild symptoms, high-arched feet and some other things. She has two more sons, younger sons, who of course are at risk of having inherited this. So we can offer the rest of the family targeted testing. So if they would like, either now, or if the family is not comfortable with that, if they start showing even mild signs, we can test them, so they would not have to go through the same kind of diagnostic odyssey that the older brother has had. So I think this exemplifies a lot of the challenges and a lot of, I think, the potential value that the program can offer. I have a couple other examples. I don't know, Deborah, how much time you want to give me.
You have up to an hour of recording time, so you're fine. You keep going.
Okay.
If people need to step off, they can always come back and listen later.
Okay. So I've got another couple examples to make. I think some important points for the programs. For the programs, it's a plural, particularly if you are in one or you're planning to start one. This is another child who came to us, as you can see here, with global delays, brain anomalies, macrocephaly, tetralogy of Fallot, post-axial polysyndactyly of hands and feet. I'm showing this. By the way, this slide is fairly busy because it's not really meant to be projected. This is one of the visual summaries we provide to the families. I haven't spoken about this yet, but one of the challenges for the families is to integrate for themselves and for the primary care provider to integrate all of the information from all of their history as well as to what we can provide through our clinic. So we have developed 2 visual summaries, each of which fits on 1 page. This is printed and provided to the family. The first is what this slide is part of, is a clinical summary of what we know in terms of phenotype and also things that we think the family and the child might have. As you can see, there's a brief clinical summary with a photograph, which is try to make this anonymous here, but in actual fact it is a real photograph. Someone about the course so far, the key evaluations to date, including the genetic study, what is our current differential, and who has been seeing this child. And we try and provide a visual summary here. Also a visual image of the clinical course, if it's improving, regressing, or plateau, and something about the family history. Of course, it's a challenge to keep this in 1 page, which is why only some of the key information is here. So as you can see, the clinicians thought that up on top on the clinical differential, there was this condition, MPPH, macrocephaly, polymicrogyria, polydactyly, and hydrocephalus, or MCAP. And this was also why this kid actually had a fairly big targeted gene panel, let's say, done, which was negative in blood. When his cardiovascular surgery was done, they took out a piece of cardiac tissue, actually repeated the panel on the tissue in case it was a mosaic form, undetectable in blood, because really the clinicians thought that this was the diagnosis and this was negative. They kept on going with a 39 gene ciliopathy panel, and they did also PIK3CA sequencing in blood. All of this was negative. So they sent the child to us, and so we did whole exome sequencing, and we found a de novo pathogenic mutation in the CCND2 gene, and based on all of the data, we decided that this was the causative gene in this case. This was, and the reason for this is a cyclin D2 gene, and has been quite recently associated precisely with this phenotype. The megaloencephaly, polymicrogyria, polydactyly, hydrocephaly is involved in the pathway that was explored through the other gene panels. And I think this points to the main reason that we and others have found to be, why gene panels oftentimes don't get to the diagnosis. This gene was identified quite recently. We went back to the gene panels for that condition, and those gene panels did not include this gene. So the issue with a lot of these presentation is actually twofold. One is the oftentimes extreme etiologic heterogeneity of these phenotypes, whereby a lot of genes can be involved. And number two, the clinical gene panels sometimes, not always, but sometimes are not really up to date in terms of the genes that they include. This is a photograph of one of those papers with this gene, and as you can see, well, you can't see because they kind of anonymized the photograph, but the phenotype, the facial phenotype was reminiscent of the published papers and some of the MRI images as well. So, this is the one-page summary which we give. Now we can add to what we know so far also what this additional genetic analysis add. So we've added this diagnostic finding. We summarize what it means for the family, and also the fact that since it was a de novo mutation, we went back to the family to make sure there were no indications of low-grade mosaicism in the parents, and there wasn't, so we were able to give this family a very low estimate for the recurrence risk. And then we came up with a summary of recommendations here. Okay, so this is patient number 2. Patient number 3, I think I can do this fairly quickly. This was a child with global delays, seizures. She was really tiny, vision and hearing impairment, seen by a lot of specialists. What was interesting here was that the congenital disorder of glycosylation screen was not normal and not diagnostic. So, given the presentation, particularly there was some abnormal fat distribution here, we thought that if we had to pinpoint our hopes to a class of conditions, it was going to be CDGs. We sent the CDG screen to a number of worldwide specialists, and their response to us was, well, it doesn't look like much, possibly, but probably not. But it's still worth try. From a testing perspective, as you know, there are more than 100 CDGs being reported. There are new ones coming out, so we were not too hopeful to find things through a clinical gene panel, so we opted to go through whole exome sequencing, and we did, and we found a diagnostic change on a rare form of CDG. It's called now CDG SLC35A2. From the fact that it's called SLC, you realize that this is linked to a transporter. It turns out to be a transporter of UDP galactose. And why this was helpful is that we were able to find a single report in which a group had tried to give galactose supplementation to a child with this condition, and they reported only a 6-month follow-up, so there was not much clinical outcome information, but they were able to show an improvement in the biochemical expression. Basically the CDG transferrin tests normalized. So we offered the family this possibility. Our metabolic dietitian had worked a plan for them. So we're working with the family to see what can be done. Again, I won't go through this, but we were able to do a couple of things. One is what I've told you about potential targeted management in addition to what we were doing so far. and also to show that this was a de novo mutation in this X-linked gene, so we were able to counsel the family appropriately. This was actually quite important, to the family because there was a young family and they wanted to have, more kids. I will skip this and go to the next. And because this shows, I think, the fact that when you have these programs, you have a group of families in which you cannot make a diagnosis, a group of families which you can, you feel confident about this, but then you always come up with a group that's in the intermediate area. You find a good candidate, but one is not confident to make a firm diagnosis yet. And this is one of those situations. This was a child with global delays, ataxia, weakness, episodic tachycardia, some, let's call them dysmorphic features, seen by a whole bunch of people who did a whole bunch of things with non-informative results. To cut a long story short, we saw him through genetics, neurology, and comprehensive care, decided to go for whole exome sequencing, and we found a mutation in a gene that so far has been associated with two forms of spinocerebellar ataxia, and nothing really else that fits. And also this did not fit because classic disease onset is later on. It's usually isolated cerebellar ataxia with no cognitive involvement. So it is a brain condition that really didn't fit sort of the early onset condition that this child had with, it started out at about 1.5 years of age and had all of these other things, going on. And the MRI of the child was essentially, normal. So, could this be a normal variant presentation? And it turns out that only a few months previously there's been a single case report of a de novo mutation in this gene, in the same gene, of a child who actually started early on with intellectual disability, oral apraxia, and cerebellar ataxia. So a phenotype which resembles much more closely, our child. So we had this to go through, and it's an interesting gene because it's associated also with Brugada syndrome, which is an congenital early onset arrhythmia, the condition. The child had episodic tachycardia, so we were able to send him to the cardiologist, have a Holter, and so on. But I think the most we can say is this is potentially, related to what we would like, say, to do. And so what we did, we have communicated with the group who published this. We put the mutation in a gene matcher, which is sort of a database for researchers that you're probably familiar with. And we actually got several matches, and we are in contact with other people. At least 2 other groups so far have reported to us, even if they've not published, kids with an early onset phenotype associated with mutations in this gene. So I think this is an evolving story, but I think it highlights a couple of things. One is that you may not get black or white answers, so one has to be open with the families as to what we know and what we don't. Number 2, the importance of follow-up, so we can learn more about the natural history of the condition and provide that information back to the family. And 3, the importance of informal networking, beyond the usual channel of published papers. And I think I will stop with that. I probably am out of time. I just wanted to let you know, where we are. We've accepted 17. We've completed the evaluation in 12. Actually, 13 now. So now we are about 13 and 9 diagnosed. So we are, a little over a 50% diagnostic rate. We're kind of, happy with that. I don't put too much weight on the actual number, because I'm sure this will be coming down as we see more patients. I think realistically, especially with patients with a neurologic component, one can expect a diagnostic rate somewhere around 30 to 40 percent, perhaps higher. What I want to highlight really is the importance of having a comprehensive approach that includes the best diagnostic means we're able to provide families, but also a really strong attention to care and provide the families with access to some form of comprehensive care, both specialist as well as through the community providers. We're also trying to, quantify and qualify the value for the family and for the healthcare system. For 4 of them, I didn't provide vignettes for all of them, but we were able to provide a pathway-based treatment on 3. We were able to avoid ineffective treatment in 1 who had sort of an osteolytic form of condition, and we were able to find the diagnosis and link back to researchers who have shown that, for example, biphosphonate treatment is ineffective in this condition. So we were able to avoid that. We were able to provide actionable information in terms of recurrence risk in several of these. I'd like to close here just to say where we are right now. We're trying to put a cost and the time to these patients, so how much it costs to see them prior, how much it costs to see them after, how many hospitalization, how much the healthcare, the global healthcare cost was prior and after. And so some of these, preliminary here. I'd like to also highlight this. We're able to estimate there were about 12 hours of average clinician time, which was not face-to-face spent, through this program. So we have to find a way to sustain this because these are not available. The problem calls for genetic testing. We did some, QI, projects trying to bring down the time from clinic visit to family results. We were able to reduce that to about 1/3, and we've seen about 20 families so far, and we want to expand our program in year 2, which has just started, and then to year 3. So I'd like to close here and see if anyone has any questions, if anyone has found this of any help.
Hey, Dr. Botto, I have a question. I'm not sure if you can hear me or not.
I can hear you. Go ahead and tell us your name, though, so everyone knows.
Sure. Hey, this is Anna Hurst from University of Alabama at Birmingham. And we have a similar in-house undiagnosed disease program, more focused on adults. But recently, we've been struggling to get high attendance at the multidisciplinary conferences where multiple consultants attend to discuss individual cases. I think the collaborative group discussions are always really productive, but how do you encourage regular participation from subspecialists who are also busy, but kind of getting that big group together logistically? How does that happen?
That's such an important point you raise, and I am totally with you that the greatest practical challenge has been precisely this, to get a group of clinicians in the same group at the same time, reviewing the same patients, and particularly because we are trying, and I guess the same is with you, we're trying to get the most experienced clinicians, those that have had 20 years of experience, have seen the classic and variant presentations. I think there are a couple ways of doing this. One is we got a strong buy-in from our department chair, and so he's been, and that is very important, and he has been promoting this in words and in fact. He has, for example, provided funding, so they don't have to see as many patients in clinic with the RVUs and so on, and we can provide some funding to their division so that that portion of their time is covered. The second thing is that, but I think this will become more and more important as the volume of patients is going to increase. It's one thing to see 20 patients a year, and is one thing to see 150 because we get more meetings and so on. So we'll see how that goes. But you need to say buy-in, and you need to schedule things in advance. It's my clinic, their clinics get scheduled 6 months in advance, so this has to be sort of a long-term commitment. The second thing is let's see. So one thing is this. So to the funding and the commitment. The second thing is it's kind of intangible, but the feedback I've been getting from a lot of the experienced clinicians is this is really something that if it didn't change their lives, it really gave them an extra amount of energy in the work that they do. In the focus groups, there's been an element of frustration in how the diagnostic process is being handled so far. Just because we can't figure things out, we cannot speak to other providers and so on. So being able to do this in this fashion really finds them much more energetic, and they really feel they want to do this, and they find a way. The point number 3 is a small point, but I'll bring it up because I've learned it at the NIH case conference, is that at every meeting I actually bring things, I bring treats, so chocolate and cookies and goodies, and that seems to help a bit. But
that's funny. We started serving breakfast, and we've noticed that our attendance has gone up slightly. So it does make a difference. Thank you.
So I'm going to add one thing because I worked at the NIH's Undiagnosed Disease Program for several years. This is Deborah Gear, and the one thing that I will say is you want those 20-year experts, but you need the fellow and the early career people that this is a publication and could give them a name. They're the ones who are going to be invested. They're the ones who are going to show up at the meetings, and then they're the ones who, even if the 20-year-old veterans aren't there, they'll go and get their input. So sometimes we would take fellows because we needed more investment from a group, so that might be a back door. and then they would turn around and present the cases at their own like departmental case conferences, and we got a lot in buy-in that way, kind of through a back door. That might help.
Thanks for bringing this up. This is an aspect that I forgot to mention. Again, as part of this clinical program, we are starting a fellow rotation program for two reasons. One is the one you've just expressed, say, Deborah. And the second, because this is really, I think, and a lot of people think this is a key educational opportunity for fellows. And the way that we're trying to maximize that is we are going to match a clinical fellow with a lab fellow. So for example, a clinical genetics fellow with a molecular lab fellow, or a neurology fellow with the molecular fellow, and their job or their rotation would be to get one or two patients from the very beginning of the process to the end. They will participate in the screening, in the summary of the clinical medical history. They will present it to the board. They will be in the clinic with the fellow. They will review the lab data, so also the clinical fellow can learn, how to do that. And we will encourage them to publish this. So that's a very good point, Deborah. Thanks for bringing it up.
So we have another question that was texted in, and their question is, in undiagnosed disease programs, what is the role of basic or more clinical researchers in the bigger scheme of rare disease? And do you want to take a stab at that one, and then I can mention about what the NIH is doing with that too?
Yeah, that's a very good question. So I think that the main point is that from a research perspective, this is really a treasure trove. These are either new conditions or very rare conditions or unusual presentations that expand the phenotype and really provide us an insight into the biology of some of these conditions and some of these pathways. So from a clinical perspective, I guess I made an example of N of 1, clinical trials. One can describe the natural history of these conditions, and that is particularly valuable if you go one step further with networking with other sites and trying to find additional patients. For the child with KCN, for the child with PRPS1, the one with the SAM supplementation, we are networking with a group in Sweden who has a family with this, and they haven't tried it. So we shared our intervention protocol with them, and so we're working that way. From sort of the basic science, it's a piece. I think there's a lot to learn. For example, for the KCN33, the one with the single other reported cases, the KCN33 is a potassium channel. And the key thing is trying to figure out the functional meaning of this. So we are connecting with some channel basic science people at our university to see if they want to take this further and be able to, for example, express this in a model organism or in zebrafish, like in Brugada syndrome, and see if they can make a story out of this. But I think the possibility endless.
And I don't know if you know this, but the Undiagnosed Disease Program at NIH has a full wet bench lab where they actually try to look variants or new genes that they find and put them into systems to see if they can recapitulate the disorder. So I think that's something that as rare disease programs throughout the country kind of keep expanding, and the more we can start, that's going to be the next step. So for all of those people that are like, but I'm a bench researcher, why are we doing this? I want you to think about this maybe being a great opportunity if you've thought about this and could be that person that would bridge that gap, that this might be something that comes up to the forefront in, I would say, in the next 5 years as we keep doing more and more undiagnosed disease programs throughout the country because they're popular, but what do we do next? We have exomes, we're getting answers, but we don't know what the answers mean. So thinking from a clinical research / bench research perspective, figuring out what these mean is going to be really kind of the next thing, I think. That's what I'm guessing. So that's why I'm hoping you might feel like this is something you might want to do even if you're not a clinician. Anyone else have questions before we wrap up? Well, Dr. Botto, I can't thank you enough for taking your afternoon to hang out with us, a long lunch break probably in Salt Lake. I hope it's not snowing and that you're having a great winter. And to everyone else on the phone call, thank you so much for joining in today. As always, we'll record this lecture. We'll post it about tomorrow afternoon. It should be up. And just so you know, our next 2 lectures coming up in February. One is on early career grants with Paula Gregory. She's one of the people in the world that's best at helping people get funded. And she's actually, the NIH hires her to come teach their fellows how to write grants. So she's going to talk to you about the input she gives NIH fellows on how to write grants. And the other person is Dr. Karen Summers. So she was one of the proponents of the 21st Cures Act. She actually works on Capitol Hill, and we're going to go up there. We're going to interview her in her office about how she feels like Capitol Hill, what they're doing for rare disease and rare disease research. So kind of getting the federal government view of it from a little bit of a different perspective. As you can imagine, I had her scheduled, but she's had to move a couple times. So that's why you haven't got an email of the exact time. So once I get it, I will email you as soon as I do. And as always, if you can't make it in real time, we'll have it recorded. Always feel free to send questions before if you know what it's going to be and you can't join us. Thanks again, Dr. Botto. Thanks, everyone, for joining us, and have a great afternoon. Bye, guys.
Thank you very much. Bye-bye.
Thank you.
Thanks.